So today I'm going to be giving a talk, as Ron says, part of this exhibit, Surviving and Thriving, and I called my titled my talk, Leveraging a Legacy of Activism, Black Lives Matter and the Way Forward for HIV Research. And so what I really want us to kind of accomplish, I suppose, this evening is for me to give folks hardly a comprehensive overview of HIV/AIDS activism, but enough of a kind of shared knowledge so that we can have a productive discussion. And then really, shift us from the past to the present in terms of activism. And I'll be specifically focusing on the Black Lives Matter movement. And then really talking about kind of how can we think about and apply Black Lives Matter to public health broadly, but also specifically HIV research. And then finally, I can think thoughts about how we can move forward, kind of from where we started in the epidemic in the United States to where we are today and how we can continue this legacy. And so, these are kind of the talks where this is right the point where I'm supposed to start throwing up a bunch of graphs about HIV-related health disparities, and I decided, I was going to kind of skip that today. So that's not to say epidemiology is not important, because I do that work. But I didn't really want this to kind of be a traditional, here's a review of the literature talk. But I do want to, not even with numbers necessarily, but really kind of emphasize, the HIV epidemic, certainly has, as Ron mentioned earlier, affected millions of people worldwide and in the United States. But particularly has hit very hard among Black and African American communities and continues to this day. And so, kind of coincidentally, today is actually National Black HIV/AIDS Awareness Day. And the CDC really uses this opportunity to try to foster awareness and understanding of the HIV epidemic and HIV prevention and treatment in Black communities. But I would actually like to take opportunity to kind of reframe this a little bit and use this day to really, provide an opportunity for us all to kind of think about basically how do we get here, and how do we kind of get out of the situation where, I can finally give a talk that isn't about disparities in the epidemic. And so, for those of you who know me, I love this idea of Sankofa. And, it refers to this idea that you can really learn a lot from not only your personal past, but kind of the past of kind of generations who came before you, and more importantly, apply that going forward into the future. And so kind of literally translated, it means it is not wrong to go back for that which you have forgotten. And I think it's with that spirit that I would like to have us understand the history of HIV activism. And so, I think one of my favorite kind of sociological theories to understand a lot of what happened in the 80s, sociologists have, what they call social death. And it's really essentially, we're all kind of aware of physical death, the individual, but social death was really this idea that an entire class of people was kind of written off. And this is essentially what happened to those living with HIV in the 80s, right? Because, we barely had an ability to even identify the virus, and certainly we were far from anything close to an effective treatment. And so people living with HIV found themselves, kind of fending for themselves, which really necessitated organized community responses to deal with the epidemic. And, there are a lot of milestones, but I think one of the earliest, and maybe one that isn't talked about a lot, are the Denver Principles that happened in 1983. And this was really the first time, kind of on paper, people living with HIV really formally stated that, this is really about kind of how society and healthcare need to really change the way they think about and treat and address HIV, and more importantly, people living with HIV. And for those of you who are familiar with the National Association of People living with AIDS, like that's kind of where that organization came out of. Something else I think is really interesting that I hope we can come back to later when I get to Black Lives Matter is there's this awkward tension between, one having to deal with the reality of HIV stigma, the other reality being homophobia, which was, not great before the HIV epidemic and certainly was exacerbated by this. And then the reality on the ground that in terms of epidemiology, right, Black folks, gay folks were the ones who were kind of being hardest hit. Injection drug users, and these were again groups of people who were not possessed of high amounts of social capital before. But then lastly, this idea that despite kind of the stigmatizing nature of the epidemic and of these social identities, the need to kind of claim ownership to these things, despite society kind of telling folks that this was not something that they should kind of want to own. And so, again, there have been a lot of really great portrayals in the media about, a history of activism, how to survive a plague, ACT UP and the kind of, in the treatment action group that came out of it, have both done a really good job of kind of archiving and telling their stories of what was accomplished in the 80s. And if you haven't read the book or seen the movie And the Band Played On, they also kind of really get into a lot of kind of just how difficult it was and how people reacted to a completely unforeseen epidemic. And I should also state, I am by no means a historian, and they required us in graduate school to actually take a history of public health class, and I was like, oh my god, this cannot be less relevant to anything. What am I doing? Give me my stats textbook and let me do public health. And my bad. It's really important to understand kind of the history of really any area of public health. But I hope you'll be able to see today why it's critical that we understand kind of where we came from if we're going to really move the epidemic forward. I think what I'm going to be talking about for the remainder of this is really how can we talk about activism as specifically applied to just not the epidemic broadly, but really HIV research. Because in some ways, this is what really, I think, set apart HIV activism from a lot of other activist movements, was the very direct engagement with the scientific and research community. They had a lot of powerful results that to this day, we can often kind of take for granted and assume that, this is the way things have always been. So, it sounds funny to think of increased federal funding these days, but the fact that we have as much money as we have, quite frankly, is a direct result of the work advocates did with federal agencies to really set aside separate pots of money for this important research. The Office of AIDS research, which a lot of us think of as just kind of it's another bureaucratic thing we have to kind of address when we're doing federal research. When you take a step back and think about it, this is pretty unique, right, for kind of all other health issues. This is what enabled HIV to kind of really be a cross-cutting research area at the National Institutes of Health, right? There's no National Institute of HIV, and even the Institute of Infectious Diseases, where a lot of this work kind of initially occurred, it's no longer siloed there, right? So kind of you see, Institute of Mental Health, the Institute of Child Development. These are all institutes that, because of the coordination of the Office of AIDS Research, are getting involved. And I think an interesting point also is, a lot of historians have actually pointed out that perhaps the reason that this scientific activism and advocacy was kind of so effective in some ways was because particularly lesbian, gay, and bisexual communities had a lot of experience working with the APA just the decade before to really lobby them to decriminalize homosexuality from the DSM. And so I think it was a powerful kind of process lesson, but also an outcome lesson that, hey, this matters, and, how kind of science and research talks about our communities can have tangible effects. And, for kind of some of the, research methods geeks in the room, right, I think this also had a really powerful effect on the way we execute and do research. So a lot of the kind of accelerated research designs that we have, that we view as acceptable now, particularly for kind of drug trials, were largely a direct result of people living with HIV and AIDS, engaging the research community and be like, this isn't okay. We don't have time for you to kind of wait 10 years to make sure a drug, is safe, and then you have to establish efficacy. If, by that time, there'd be no one left to take the drugs. People were literally dying every day. And so, we have a lot scientifically even to kind of owe to these advocates. So, like I said, these accelerated research designs that, they didn't sacrifice scientific rigor, but they did really require scientists to think through, okay, maybe an RCT with a placebo is not ethical, right? We know that doing nothing, we know how this is going to end. So as soon as we can establish the safety of these drugs, we have to get them into the hands of people who could possibly benefit from them. And there's also, what they're called parallel tracks of research. So typically, right, if you're kind of taking one drug, that would exclude you from participation in another clinical trial because we want, it's very nice and neat in science, right? We manipulate one thing at a time and something happens, we're pretty confident we know what's causing that. Right, but, oftentimes, I think a really compelling story was, one gay man living in San Francisco was like, hold up, like, this one trial is for this drug that will help me, basically address, cytomegalovirus, an opportunistic infection, so he wouldn't go blind. And the other trial he had to decide between was the one that was, potentially going to save his life, right? So, what kind of choice is that to have to make, right? So, like, do you want to risk, going blind? Do you want to, take this other, also toxic, probably, right, drug and hope that maybe it extends your life expectancy by a few years? And so, these were the decisions folks were making, and, we had to really come to terms with the fact that, okay, the scientific process right now is not equipped to address the realities on the ground of this epidemic. And similarly, if you were the wrong age or the wrong gender, oh, sorry, you don't need our clinical trial, good luck, we'll come back to you when we're ready, which, again, not an option for people, so. What I really, to kind of start shifting, as important as that advocacy, was and remains, I think perhaps one of the most valid critiques of this was, the invisibility, quite frankly, of women and people of color. And, we can still see how that has effects through this day. And I'll come back to this later, but the availability of pre-exposure prophylaxis, right? This pill that you can take to literally prevent HIV infection is still not in the hands of these communities that need it the most. So what are we doing? And so I think this aptly named exhibition, Surviving and Thriving, is important because we need to acknowledge kind of the challenges that we went through, how people are surviving and thriving, but I think that also demands of us to think about, who didn't make it and why, and what can we learn to make sure that kind of moving forward, we have, we can be as inclusive as possible, so as many people can claim that they too are surviving and thriving. And so, because I like, as opposed to reading a history book, you can watch a fun movie or something. I imagine a lot of you here have seen Paris is Burning, right? Yes. If you haven't, you should. It's on Netflix. It's great. It's a documentary about the house and ball community in New York City, and it's not intended to be about the HIV epidemic, but it's a documentary about gay and transgender black folks in New York City in the 80s and 90s. So it would be impossible for the HIV epidemic not to come up. And I think what's particularly well done with this is it really kind of highlights the importance of thinking through a lot of these intersectional considerations. So kind of where you are located socially, how does poverty matter? How does racial segregation matter? Homophobia, transphobia, and inequities in the criminal justice system. And so, again, in the documentary, really, I think, interesting example, right? It talks about how folks kind of kicked out of their church, of their families, and kind of the things they have to do to literally survive day to day. And then, kind of by the time you get to the end of their story and learn that, they've become HIV infected, you're kind of left with this, sense of almost inevitability this was going to happen, and in a really, kind of, I think, sad, disheartening way, this is hardly the biggest one of their problems, right? HIV was really kind of just another thing of a list of ways that society kind of had failed to serve them. And so Marlon Riggs, I think had a really great quote where he, in his kind of semi-autobiographical documentary said that, it was important that we shatter the nation's brutalizing silence on matters of sexual and racial difference, which really meant, we can't just think about or address the HIV epidemic with one broad brush. There's a reason that certain communities are being hit hardest, and if we, kind of don't address them head on, we're going to continue to get the same results that we're getting. And so to kind of shift to current day, Black Lives Matter, is again, I'll give you the super kind of encyclopedic definition, right? So it's a national movement, but it's really kind of organized around local chapters that are really focused and dedicated on addressing issues that are pertinent to kind of Black life and Black validity and empowerment, and really thinking about ways that we can address social structures that sustain these disparities. So again, poverty, violence, racism, incarceration, and of course, where this movement really was born out of was, direct response to the murder of Trayvon Martin and then the subsequent acquittal, right, the following year. And so it really became kind of the galvanizing point for this. And, it's since then really been, police violence is certainly probably one of the primary issues, but it's really a cross-cutting, multiple issue social movement, where this activism takes on multiple forms, including protests, and I think it's hard to understate the impact that social media has had on helping Black Lives Matter organize, as well as kind of disseminating knowledge of Black Lives Matter to the country at large. And so, I think it's also important, if we're going to talk about activism, to think about structures and characteristics of, maybe why Black Lives Matter has been able to accomplish what it has in the few years it's kind of formally been in existence. And so, Black Lives Matter describes itself as not leaderless, but leaderful. So really kind of putting organizational power in the hands of local folks on the ground. And that it's intersectional, and that it, by design was meant to include as many kind of people as possible. I don't think it's unimportant to talk about the fact that this movement was, founded by Black queer feminists, right? And, I think by, again, I'm not going to give a lecture on queer theory or feminist theory, but, these are perspectives that I think are really nice for a social movement because they are so strongly rooted in the understanding of multiple forms of oppression. And if you remember, right, what was one of the strongest critiques of kind of HIV activism early on was that it didn't fail to kind of really build these coalitions between different groups. And so this alliance building approach that Black Lives Matter, isn't perfected by any means, right, but is, explicitly wrestling with and trying to address, I think is really, really important for us to think about moving forward. And so, why does this matter for public health? You know, first thing I would say is, the language that we use in public health is very kind of specific to our discipline. And it's not the exact same language, right, that, I mean, like we don't even use the same language across departments in this building, right? Let alone like School of Medicine or like a social movement. But, I think if we're going to think about how we can develop these really effective partnerships, that's kind of one of the first things we have to address. And I think maybe the kind of linchpin of getting on the same page is really social justice. And I think that is one kind of principle and even term that, right, we get that in public health, right? And we embrace that, and we understand why that's important. And that's certainly true for Black Lives Matter as well. And again, while I don't think, they would use kind of the Lincoln Phelan fundamental causes vocabulary, that's essentially what Black Lives Matter is also articulating, that there are these systemic structural ways that we've organized society that are continually responsible for the disparities that we see, which means, the HIV epidemic is certainly a problem, but right, it's also in perhaps more appropriately thought of the symptom of the problem, of multiple social problems. And then lastly, I do HIV research because I'm concerned with kind of, unjust morbidity, unjust premature mortality, which, kind of the ultimate, right, public health endpoint. And that is certainly no different than what Black Lives Matter is really advocating for, right? This is literally about people's physical wellness and safety being put on the line here. And so, I mentioned PrEP earlier. And I think PrEP, we're at an interesting kind of time point, right? So, it's only been like 5-ish or so years since kind of PrEP has been commercially available, and it's done a lot of good, certainly. But, given where we know where the burden of the epidemic is, and that's certainly going to be Black and Latino, gay, bisexual, and other men who have sex with men, this is the exact same group that is not getting access to PrEP, right? And I don't think that's surprising to anyone in this room, right? If you don't have health insurance, you're definitely not getting PrEP, right? If you don't have access to a healthcare provider who knows about PrEP, you're not getting PrEP. We've kind of, I think, a lot of us doing this work are, starting to understand kind of anecdotally and through qualitative research that, there's still a very real, palpable stigma around being gay, right? When you kind of come out to your healthcare provider and, the idea, why do you need PrEP? You should be using condoms, right? So these are all things that are kind of coming together and really exacerbating a disparity where, ideally PrEP should be a tool to kind of reduce incidence. And so, this is a great opportunity for us to, I think back to kind of what happened with the initial rollout of antiretrovirals, why there was such a lag, before we kind of really got these into the hands of communities of color, which, we still haven't sufficiently done by any means, right? But, the train hasn't left the station totally, so to speak, because PrEP is still a pretty new tool. But this is really about kind of social justice and access to these health technologies. And I think another great example of where we can think about how public health and HIV can intersect with Black Lives Matter around these HIV criminalization laws. And so, for those of you who are unfamiliar, in most states, failure to disclose your HIV positive status to a sexual partner is a felony, which can result in varying amount of jail time. And and the intent being, right, people should have discussions with their sexual partners so they can can make informed choices, which is great, right, on paper, right? I think no one here would disagree that being informed and being empowered to make decisions about your sexual health is a good thing. But we also know HIV stigma is very, very real, and so there are very legitimate reasons people hesitate to kind of disclose their HIV status. And so, even if you kind of, let's say, are virally suppressed and you use a condom with someone, you could still be convicted of a felony in most states in this country. And so, we've seen evidence that the existence of these laws actually deter people from HIV testing. And so, essentially these criminalization laws are ineffective, but perhaps more problematically, they're differentially applied to communities of color. And so, I think example many of you may have heard of in the last few years, so Michael Johnson, who lived in Missouri, was convicted under the criminalization laws in that state for exposing his sexual partners to HIV. Now, I think, so he got 30 years. He was sentenced to 30 years in prison for this. And now to give you some context, on average in the state of Missouri, if you're convicted of physical assault, it's 20 years. If you're convicted of second-degree murder, it's 25 years. So, these laws, have a tendency to be used in a way that pathologizes black bodies. And so he literally got more jail time than most people in that state get on average for second-degree murder. And again, just, another contemporary comparison, right, who kind of, which is, I hate to bring up Charlie Sheen, right? When kind of he came out as HIV positive and talked about how he had exposed his sexual partners to HIV, it was a very different kind of treatment, right? It was like, oh, ha, 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 quirky, crazy Charlie Sheen. He did not face jail time, right? He was a rich white man with social capital who didn't have the same access, and essentially wasn't being tried under the same legal system in any way, shape, or form as Michael Johnson was. And Essex Hemphill, who's one of my favorite poets, who died in the mid-90s from HIV, has this great poem called For My Own Protection, and he has this, kind of tongue-in-cheek line, right? I don't want to wait for the Heritage Foundation to release a study stating that black men are almost extinct. And, and I think the first reaction people have is like, ha ha ha, the Heritage Foundation, like, of course, those evil conservative think tanks. We could talk about that later. But I think it's also, if we're going to be fair, we have to, that's on us, right? It's really also, I think a powerful critique about the research process generally and how we tend to, we're many things, but I don't think quick is probably our greatest strength. And so, how do we think about making sure that we're not, essentially, we have to, wait 10 years, right, to kind of, before our populations go extinct, so to speak. So, again, so I think what this means for us in applying this perspective to our research, so again, it's really about identifying shared language, but in terms of just even some of our methodology, we talk the talk, I think, right, about the importance of community and structural intervention, and then we shy away from doing it because it's admittedly very hard to kind of implement and equally harder to kind of assess the effects of, right? Our entire research paradigm is based on the randomized trial and, statistical power. And so when you're doing community level interventions, right, it's one thing to get 500 people in an intervention. It's one thing to get 500 communities, right? And so we have to really rethink what does it mean for us to evaluate these larger community and structural interventions. And then also, again, and I'm guilty of this too, but, I always kind of mention racism in my discussion section, right? But, are we assessing racism? Like, we do a good job of assessing race, but, right, that's not the problem, right? It's kind of racism, which treats people differentially and provides different resources by race. That's the issue. And again, and I think Nancy Krieger wrote a really great piece where this was about poverty, but, it really talked about that we weren't doing our job as scientists, quite frankly, by failing, when we failed to address these structural issues. And so, this means that we're going to confound race with racism. It means that, every time we find an association between low education and risk of HIV infection, what we're really missing is kind of a history of racial segregation and kind of how that influences the educational opportunities that you have from the day you're born, and how that literally, concentrates poverty in areas, which leads to, risk of HIV infection, which is just a function of where you live, right? So, my department had Jose Bauermeister here yesterday, and he had talked about, kind of even controlling for all these individual level effects, kind of how space and place can, pattern your risk of HIV infection. So these are, again, I think they're ethically important, but again, for no other reason than, we are scientifically invested in making sure we're getting these answers right. We really have to, I think, come to terms with this. And so, I think this is awkward for a lot of us, right? A lot of us like to think of ourselves maybe, or at least we're in some ways trained as scientists to kind of be like, well, we're above activism, right? We produce knowledge and we put it out there, and then those people can kind of run with it and deal with it. And that's, we should have learned this from, the early epidemic. That's not how we kind of do the best work. We do the best work when we're engaged with the communities that we serve. And that means, yes, we need to, publish our research in journals, but we have to also think a lot more critically about disseminating that work. And what does that look like? Honestly, I don't know. Like, I don't think, we're not trained that way, and I think we have to really rethink, as scientists collectively, how do we kind of retrain ourselves and train our students to do this work, and then, how do we value this work, right? One of the first things I always hear, right, is like, this would be great, I'd love to do this, but, the metrics from which I'm evaluated on as a faculty member don't really value this kind of work. And so, we have to literally put our money where our mouth is if we're gonna be serious about this. But, I think there's some exciting examples kind of already starting to appear. So, so some folks at Harvard have already started kind of advocating for police-involved violence, right, and death to be reportable public health data, so that we could finally get in one location the ability to kind of evaluate and understand what's happening with police-involved deaths, so we could actually quantify, these acts of violence. And this is just one example of many. And again, so these are also, I think, different public health entities that you see have already kind of started to be pretty explicit and head-on about thinking through Black Lives Matter, how they can apply that to their work. So the American Journal of Public Health has been pretty gutsy, I'd say, in the last few years. The Black AIDS Institute, has a really interesting report, talking about how increasing access and availability to PrEP among Black communities is an issue about, for Black Lives Matter and what they're doing to kind of work with their local chapter of Black Lives Matter. And AMFAR released a really great brief that really, addressed, basically, if we're thinking through this lens of Black Lives Matter, how are we doing as a public health community? And so again, moving forward, I think this means engaging community, at kind of all levels of the research process, and listening to advocates. And again, there's a history of us doing that in HIV research, and I think we can't forget that. And we have a lot of, a proud history, I think, of being able to kind of work with communities, and we shouldn't forsake that. It also means that, we have to start thinking about working with people we haven't worked with before, right? So, I don't know if she's here. Yeah, so, someone in our research group, was kind of saying, one of the best interventions we could do, like an employment intervention, right, for transgender people. Like, that is public health. So how do we kind of think about that as intervention in, criminal justice and housing? And then there's also advocacy we can do kind of as scientists directly pertaining to science. So, weeks ago, the Office of National HIV/AIDS Policy like vanished, right? Like it no longer exists, right? We collectively can't just be like, oh well, like, and then why, what do we do as a public health community to kind of make sure that, the role of this office is not, just neglected, for the next however many years, right? This office had an important role to play in coordinating the national response to the epidemic. And we can't just kind of let that go. And then also, folks have been really mindful of thinking about what does it mean to think through the way the NIH even funds research, right? So right now the NIH is structured in a way that funds primarily based on disease outcome, right? But, the entirety of Black Lives Matters is like, okay, well, disease outcomes, in many ways, like those are the endpoints, yes, but it's these shared, fundamental causes and social determinants that are really the issue. And how do we challenge ourselves to shift kind of where we start conceptually in public health? And again, thinking about, anti-racism as something we explicitly address in intervention, and also being mindful that we prioritize kind of real-world effectiveness in communities alongside clinical efficacy. And this isn't just true for kind of drug trials, right? This is true for our kind of behavioral and community interventions. So, it's great if we can kind of make it work in the confines of an RCT, but if it doesn't work kind of in the community, which is the whole point, then what have we been doing, right? We've wasted time and money. Tony Fauci, I think, said it pretty well when he had really, I think, challenged scientists to say, we need to really think about this delicate balance between adhering to the fundamental principles of science, some rigidity, at the same time, having the flexibility to make things work, right? Because, at the end of the day, public health is an applied discipline. And so we have to really be sure that, the science that we created isn't kind of the barrier to making sure that our research is useful in the real world. And so this, means, I think, moving forward, really bridging this gap between research and activism. And, I get it, it's awkward, right? That's not something we're trained to do. It's not something I think we have particularly a handbook for how to do. But I think it's something we have to do, right? The status quo, which has been going on for decades, isn't working. And so, what is kind of the new HIV scientific advocacy, 2.0? What does that look like, right? And I think we have to also acknowledge as HIV researchers, like our science is a direct beneficiary of activism. And so we have to be mindful of that and think about how we can engage in a meaningful and thoughtful way with activism. And so, again, to conclude, I want to go back to that idea of Sankofa, right? It's not wrong to go back for that which you have forgotten, and hopefully haven't forgotten, right? The legacy of HIV activism in public health and HIV, but I think we can all do with a refresher and recognize, particularly Black Lives Matter, for the really rich opportunity that it is for us. I think it just means, we can't just wait for something to happen. I think it's about being intentional, and kind of, getting out into the fray and getting messy, right? And I think Martin Luther King Jr. Had a great quote, which, said, we have to be careful about being more devoted to, order and the status quo than justice, right? So, again, no one said this was going to be easy or comfortable. I don't know, I think it's what makes public health a little bit more fun. So, yeah, that's all I have, and hopefully we can have a great discussion now. Thank you.
It was even kind of referred to in your presentation because in the header for that slide you use the hashtag because that's so iconic and the movement is so tied to Twitter specifically and social media in general. So I'm curious to know what you think about, as researchers, kind of that trade-off between formality and accessibility, where we're used to publishing in journals or writing, long form, very formal things, but that's not necessarily where the people are. So do you think there are things that we can learn from subject matter in terms of the way that they disseminated their information in that regard?
Yeah, I mean, I certainly, I think we've seen, for better or worse, right, social media used as a very efficient way to disseminate information and other things. And again, I'm not saying, right, we need to reduce every single paper we write into like a 140 character tweet, right? But, it does, but I do think it means, I think we have to stop fooling ourselves, right, that like, I'll put a paper out there, someone will find it and run with it and do great things, and maybe they will, like, 6 years later, right? It's fine, right, that journals are kind of the primary way that researchers communicate with one another, and that's great, but I think we have to be really clear, like, folks are not going on, like, checking AIDS and behaviors table of contents every month, right? And again, so, I mean, to your question, I don't know, right? Like, they did not teach me how to do this in graduate school, and I think a lot of us are making this up as we go along, clearly. But I do think it is worth thinking through alternative ways of dissemination, certainly, right? We see conferences kind of that have popped up that are certainly by design more inclusive of kind of, folks from the community and, non-formally trained scientists as one kind of, foot in the door. But I think we have to figure out the social media piece for sure, because I mean, like that's where people are, right? And so we're not there, so we need to fix that. If you have any bright ideas, I would love to hear them.
Since, I'll add a question, since PrEP is becoming more common, especially probably the past 5 years or so, like you mentioned, would you say adherence is still a big issue for that, and why?
Yeah, I mean, well, I think adherence has been difficult for people living with HIV, right? So if anything, it seems like it would only be kind of more difficult for PrEP when, your kind of health isn't at stake in the same way that it is for folks living with HIV. There's certainly, I guess take a step back. I mean, adherence is problematic for kind of almost any sort of drug therapy, like, for anything ranging from high blood pressure to PrEP. But the kind of stigma around the virus certainly, I think, has can make it difficult for that. And I think other reasons that we're starting to see, right, is, issues of kind of HIV fatigue. And I think that the tricky thing with PrEP is it's like functionally, in terms of behavior, not that different from taking an antiretroviral if you were living with HIV. And so the kind of perceived consequence of failing to adhere to your PrEP regimen, in some people's minds isn't like that big a deal. I will say, I think we're seeing some pretty interesting stuff happen. Like Jamie Egan here at Pitt is doing a really cool study where he's basically saying, is there a way we can get folks to identify episodic risk in their lives, and that way they can worry about adhering to PrEP kind of during those periods of high risk, and then, kind of they're able to kind of go off of it. Because I think something about being told, oh, just take this drug every day for the rest of your life. Okay, like I don't take my multivitamin every day, so, yeah, I think there's a lot of room for us to figure something out other than like, just keep taking this pill every day. Because it's not, it didn't even work in the randomized control trial, right? People weren't doing that. So I think we need to figure out alternative dosing strategies. And again, there's also, can we formulate like a long-acting injectable form of PrEP, right? That's kind of also in the works. So I think there's, kind of some opportunities.
So, in light of the most effective means of distributing antiretroviral therapies to communities of color, what do you feel are the most necessary and possibly effective social and institutional means of ensuring that the people who are most hard hit, specifically say Latino or Black communities, receive PrEP?
I mean, I guess I'd say if I could pick two things. I mean, one, access to healthcare, period, right? So, you know, we know that kind of, certainly at least Black folks tend to be way more likely to live in the South. And those are the states that, you know, have, for the most part, opted out of Medicaid expansion. And that's been one way a lot of people have kind of started, you know, getting entry into the healthcare system. You know, some other states are playing around with, you know, is there a way we can use ADAP funding or kind of Ryan White funding to kind of, you know, there's a lot of like regulations about how well you can and can't use this funding, but, you know, can we use it for other things and then redirect that budget, you know, to provide PrEP access. So I think that's probably the big structural piece. I think another piece is around kind of healthcare provider training. You know, in Pittsburgh, right? You know, I know kind of, you know, it's like, oh, I got to send you one of the, you know, these following 8 to 9 places, right, where I know they have folks who know what PrEP is and who are happy to prescribe it. But a lot of people don't live in communities where they have access. You know, kind of the best case scenario, you have a physician who just, I don't know what PrEP is, or worst case, like, won't give it to you. So I think, you know, thinking about alternative ways we can kind of get PrEP in the hands of people, you know, it's a drug, so we can't like bypass physicians, but, you know, is there a way you could maybe virtually communicate with the physician if there isn't one kind of local to your area who is knowledgeable about PrEP? But yeah.
Kind of along with that, I'm interested in what you think about educating health professionals. So you talked a lot about research and how that can work with the Black Lives Matter and the community, but how can research and the like active community, how can they work together to activate health professionals?
I mean, that's a good point. I mean, I think, you know, we have I think, healthy cohort now of kind of clinical researchers in HIV. And, you know, to me, they seem like a natural kind of entry point into that, you know, because they, you know, engage in research on the one hand, but, you know, they're still seeing patients, right? And so I think folks who kind of occupy that professional role, you know, I think have a much better sense of the kind of, you know, one-on-one realities of the clinical encounter. And, you know, I think, you know, not to like, you know, pass the buck on, but you know, right, that's not my expertise. Like I have no idea kind of what those clinical interactions are like. But we have people who do that work, right? And so I think, you know, approaching them, be like, you know, what do you think, you know, would help you, like, you know, if we wanted to kind of talk to your colleagues about PrEP, like what does that mean? Does that mean every physician needs to be knowledgeable about PrEP? Probably not, but you know, maybe it's knowledgeable enough so you know where to send them within that kind of healthcare system. I don't know. And it probably looks different depending on, you know, if you're in a, you know, private family medicine, you know, versus like, you know, some behemoth organization like UPMC. So, but yeah, but I mean, I think they seem like the natural kind of starting point to have that conversation.
I'm interested to know, I come from South Africa, and I wanted to find out from you, what is your view on the test and treat? You test them, and immediately you find that they're positive, and then you start treating them, irrespective of the other CD4 counts. So what is your view with regards to testing and treat, notwithstanding, of course, the challenges that come with adherence and non-compliance? What's your view?
I mean, I think we're now pretty, you know, reasonably confident that, you know, at least clinically, that makes a lot of sense. Just because, you know, the kind of side effect profile for a lot of these drugs are so low that basically the benefit of getting people on treatment as quickly as possible outweighs any sort of potential risk. You know, and I think the, you know, additional benefit of treatment, aside from, you know, that it, you know, you're individually healthy, is that it, you know, essentially eliminates the ability for you to kind of sexually transmit infection to, you know, other partners. And so I think for those reasons together, I think it's an appropriate strategy. I think, you know, and also practically, right, you know, it's easy to make it sound like, you know, you get diagnosed on Monday, you're in the physician's office on Wednesday, you have like a pill in your hand on Thursday. But reality, we see this process takes so long that like we basically just don't want to lose people. And so I think kind of practically the value of test and treat is like we don't, we want to keep you like in the system because it's just so easy to kind of lose people. And we lose people who like, you know, they've been coming to care for years and years and they vanish. Did they move? Are they here? Are they run out of insurance? You know, it's too easy for people to fall through the cracks of at least this kind of fragmented healthcare system in the U.S. To where I think, you know, I think that's where the kind of best practice is for now. And, you know, I mean, I'm for it.
I'm interested in your thoughts of what you think the best way is to advocate for access to new technologies during the research period. Because what we saw with PrEP was that even though there were trials in communities of color, right, and we always knew that there was going to be a concern about access, we continued on with the trials and said that's not part of the research question, and therefore, once we figured out that it worked, which we had a good idea that it did, now we're struggling with great technology, but having a really hard time rolling that out. And so is there a better way to advocate for that during the research process as we think about cabotegravir and other kinds of, you know, new tech, Maraviroc and other things that are coming possibly down the pipe?
Yeah, I mean, I think that's, you know, I mean, it's hard, obviously, right? You know, I think, so a few things I think are promising. So one, right, I think we've seen certain trials have a much more, like, intentional focus on, not just, like, right, you know, I think there's a problem, right? I think it's easy for us to confuse community engagement in research with, like, recruiting people in research. Like, engagement is not, like, begin my study. Engagement is, like, okay, like, are you going to help us design and implement this study? And I think, you know, like, so some HPTN projects have actually been really successful, right? Kind of involving members of the community in the actual kind of implementation and design of that research project. And I think, you know, it's like funny because you talk to these people like, I was actually really surprised. They had really great ideas. And like, it only helped our science. I'm like, of course it did. Like, so I think that's an important thing. And also, you know, so Alan Steckler, this was probably 10 years ago now, AJPH, wrote an interesting piece talking about the need for us to essentially kind of prioritize external validity as more than this like secondary scientific concern, right? The process is basically figure out if the thing works, and then once it works, we can figure out the problem of like making it work in the real world, right? And he was like, well, like, yes, the thing has to work for, you know, of course, but we should be equally concerned, you know, if it has no capacity to work in the real world. And I think, you know, HIV is a great example, right? Like, condoms work, right? Like, but the reason we've had to kind of continually go back and think about other technologies is because, like, they have a limited real world application, right? People don't like to use condoms consistently. And so, you know, I think, I don't know what that means exactly, kind of, you know, like I hate to impose like another, you know, requirement on any sort of research grant, but I don't know, giving people better scores or something, you know, if they kind of have an explicit plan about how they can think about evaluating real world effectiveness in some capacity, like in their trials. Again, I don't, you know, it's tricky, right? But I think we have to at least start wrestling with it, right? And kind of.
Eric, you said something that really I've been sitting here struggling with as I've listened to your talk, and it was the idea that there was this gulf between activism and good science, and that and that's the way that we've been trained, and that's the way we've been socialized. And that was the way the AIDS research endeavor rolled out. But I'm old enough, and I've been at this game long enough to remember in the early days of the AIDS epidemic, that was not true. That when we did our early studies in San Francisco, I worked with my counterpart at the San Francisco AIDS Foundation, and that when we would find interesting findings, I would work with my counterpart, and the next day it was on ads in the local gay rag, informing gay men what some of the risk factors were for behavior, for high-risk behavior, like substance use and so on, depression and so on, and all that. And the successes that we were having in fighting the epidemic and how things were actually improving. And that we never waited to publish in the HAPH. We immediately went to our counterparts in the community and worked with them to try and educate people so they could survive. And over time, we all became very solid with the professionalism of HIV. It was as if the machinery at AIDS Inc. made it impossible for us to keep those kinds of early partnerships going. Everybody got professionalized, and we kind of quit talking to each other, and the flow of information became kind of this fire hose that we were all expected to drink out of, and nobody could actually take the time to read these millions of articles that were coming out to actually distill it so it could be used by the community. And where I'm going with this is I don't get why it is that it is unprofessional for us to also think of our work as activism. I don't get why, when we do our human subjects applications, there isn't a section in the IRB talking about how we have a plan to give the information back to the community so that it can be used. I don't get why we're not trained as public health professionals to actually give information to communities and to partner with communities so that it can be used, because when we write our grant applications, the very first paragraph of those R01 applications talk about how this information could transform the health of communities, but we never are given the tools to do the handoff. And I think that this is something that we all need to think about as a discipline, about how we're failing the communities that we supposedly serve. And there must be a better way to do this. And the simple little things that I did very early in the AIDS epidemic, and that we kept going until the professionalism, killed all of our free time, might be an early model that we can consider.
Well, I mean, I think your example, one about the grant thing, right? We all kind of write that little public health significance statement 10 minutes before we submit the grant, because we know that's not really being evaluated at the same level as the method section, right? But you'd really think about kind of engagement and dissemination as part of the research methods process, right? I think if they cared, that's where it would go in the grant application, right? Not in a 2-sentence summary. That also means that, they need to, money has to go into that, right? Not a lot, but something, right? And I think an interesting example, so a few of us were in Durban for the International AIDS Conference in July, and there was a talk about PrEP, and a bunch of kind of activists interrupted the scientific session to kind of demand access to kind of antiretrovirals and PrEP. And it was clearly disruptive. That was the point, right? And admittedly, that's why I remember it. I think it was interesting for the rest of the conference, you could just kind of hear these conversations about oh my gosh, that was great, it was wonderful, blah, blah, blah. Well, it was okay, but I really wish they didn't, disrupt the scientific session, and there's a time and a place for this. And so I think, again, I don't think a lot of us really consciously be oh no, I think we're yay, activism, but then I think when we're kind of confronted with it in unexpected ways, we often kind of don't know how to deal with it. And again, I don't think it's supposed to be easy. And I think if we could kind of get back to harnessing a lot of that energy kind of, in the mid to late 80s around people working together a lot more closely. I think certainly a sense of urgency, right, had a lot to do with that. And so I think that's part of it. And I don't think anyone wants to kind of have to be presented with that again. But but yeah, I mean, it really seems like only like a win-win situation, and I just don't think, you know, we're there yet, or again, but.
My point slightly picks up on what you said, but from a slightly different angle. I've got experience of working with organisations in the UK that are very grassroots, community level, small organisations that are often receive funding for preventive interventions for HIV and work with communities. But a huge stumbling block for them is that although they're very passionate and very knowledgeable and have wonderful access to people and communities, they tend to struggle to prove their outcomes and to show the value of their work to the people that are giving them the funding. Is that an issue over here?
Yes.
Also, any thoughts on that about what can be done?
Gosh, that is the killer. I mean, I don't know, right? You know, someone was having this conversation the other day about how even like agencies that are funded to like do HIV testing, like they're not only like they're funded to do like HIV tests, and then they're funded like at a higher rate when the tests come back as positive, right? You know, so there's this like weird perverse incentivization for, like, obviously you want to kind of identify unknown positives and kind of demonstrate that you're kind of doing that work, but really, yeah, like the metrics in which we use to kind of show what people are doing, you know, needs to perhaps change it. And I think, again, back to, you know, I think if we think of HIV more as kind of one of many kind of symptoms of underlying social issues, then it would open up a kind of different, I think, domain of metrics that we could use, right? So, you know, like, yes, HIV testing is important, but like, you know, how many people did you link to like a social service that they needed, right? I mean, like, that's an important thing. And, you know, even if it's kind of difficult for one organization to kind of empirically link all these things in a causal chain, like, as a field, we know matters. And if we say that matters, then we need to start, I think, being more inclusive of different types of endpoints. But, you know, I mean, I think a lot of community organizations address with that. I mean, even like researchers, like, you know, we always kind of, I think, like write our research grant applications with like, you know, the outcomes that we know they will like, and then we do stuff we want to do anyway, and like, and yeah, I don't know, it's like, but yeah, I mean, long answer, like, no, we are definitely not any better.